Hi everyone, I'd like to do a shout out to our sponsor, Bako Diagnostics. Early detection is the single most important factor in improving patient outcomes. The Bako Diagnostics team recognizes how impactful a podiatric physician can be and remains committed to supporting you in your role as the first line of defense in diagnosing conditions of the lower extremity. Thanks to the unwavering support of their clients, Bako Diagnostics has been able to give back to the podiatric community for 16 years by providing podiatric educational resources and advocating for the position. Bako Diagnostics, helping podiatric physicians keep America on its feet. If you have not yet had the opportunity to utilize Bako Diagnostics services, get started today by sending an email to corporaterelations@bakoddiagnostics.com. The first 50 podiatry offices who request a starter kit will receive a Dean's Chat mug. Hello, everyone. Welcome back to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and co-host for the Dean's Chat podcast. Once again, I'm with my co-host, Dr. Joanna Richey. Hi, Joe.
Hey, Jeff. How you doing?
I'm doing great. I'm in Florida, and it's finally gotten warm, so life is good.
There you go. Well, it's absolutely gorgeous here. It's 81 degrees outside. Sorry to all of the East Coast people. I was talking to somebody in Pennsylvania today, and she's literally freezing. So, it's the reverse. When it's 120 outside, we'll have those moments. But for right now, it's absolutely beautiful.
Very good. Well, Joe, we have a phenomenal guest again today. No stranger to Dean's Chat. Larry Oloff. We're already on first name, so let's just start with it. Larry, Joe, and Jeff.
Perfect. Hi, Jeff. Hi, Joe. Good to see you guys again.
It's great to see you again, too, Larry. And thank you so much for coming back for part 2, because we didn't really even get to scratch on the surface of you being the residency director for a program that we have students that are interested in. And I know there are students across the country that are interested. So you are currently the residency director at the podiatry program at Stanion, University of California, San Francisco Health Center, formerly known as St. Mary's, for those of you that are out there that name changes and affiliations change over time. So tell us a little bit. You've seen a lot in terms of changes through residency education. You've been an advocate for continuing to advance the profession to have high quality surgical education. What's your favorite part of being a residency director?
I think it's always improving the level of education. I think what's happened over time, and everybody always talks about gaining acceptance by the allopathic community, the medical community, is that we mirror what they do and by their standards. We live in an allopathic medical world. I mean, essentially, right? Because we all function mostly in hospitals and stuff. So we can't be that dissimilar. So, in the early days, and this is before you guys, I mean, not everybody got a residency program. There weren't enough programs go around. So what happened is the people that didn't, you can imagine this, didn't match up. They would do, clerkship, kind of like clerkship, they would do like journeyman positions where they stay with a doctor, for a year and try to learn the trade, and then go out on their own afterwards. And 1 year residencies were the rule, then became 2 years. I think McGlamry's program, Atlanta, was the only one that had 3-year program, I think, for a while. And then look at the changes happen. So we keep trying to mirror that, and with that became the burden of a rotation, certain requirements and that's changed over time also. So I can tell a little bit about our program. So I've been involved with this for, more like as program director for about 8 years, but I've been involved with the program much longer than that, where the residents would rotate with me when I was back in SOAR. So this goes back 100 years now. So I always enjoyed having them. For a staff member or as residency director, we do that because we love it. We love education like both you guys do, but we also do it because it keeps us on our toes. It's educationally beneficial for us, to read articles and this and that, to interact with them, making sure we're one step ahead of all our students, and it's healthy. It's a very wonderful symbiotic relationship. Okay. And that's why I love it, I think, so over time, so our program was in a hospital that had 3 teaching programs before UCSF. It had podiatry, orthopedics, and medicine. And so I would sit on a committee involving all three, and they gave me opportunity to see what other programs are doing about. And they had the ACGME standard, we had the CPME standard, which wasn't all that dissimilar. When we would get together, we realized how similar they were actually, and certain requirements. Now, we have some weird things in ours that should be changed. For example, I learned that, we would have a requirement to have advanced life support for our residents. Well, the medicine residents don't even have that. The orthopedic residents don't have that, so it's not an ACGME standard. It's kind of interesting. So there's some things we should look at them and kind of modify accordingly. And so our residents go through a very structured aspect. I think this is what's changed since I was a resident. So I went to a program called Delaware Valley Medical Center, and Tom Malillo, I don't know if you know that name, was my program director back then. He had just left as co-chief of the surgery department at the Pennsylvania school, and Goldfarb was the other person there who has the Hershey seminars, which interesting stories about that also. But it was fine. I wasn't as smart as Jeff in terms of getting into Kern Hospital, which was my first choice. Another story. Did I tell you that story, how that happened? Okay, I'll tell you a funny story about that in a second. So we have like 2 months of medicine, and our residents are on the first year, and most of their requirements are done in the first year, and so they are the medicine resident. They assign their patients on the floor, they take care of it, they have to answer to the chief medical resident. And they go through a little bit of shock in the beginning, which is fine, because especially in this era of with the COVID and stuff, a lot of the students didn't have a lot of clinical exposure. You probably noticed that too. So when they come on board, and this wasn't just ours, they had the same problem with the orthopedic residents. So we have to give them refresher courses, and stuff like that, just to bring them up to speed. And that is better, I think, moving in the better direction. So they would do that. They do all the other requirements that the CPME requires. We have great vascular surgery rotation right now, and we have the great anesthesia, and they work in emergency medicine, orthopedics over Highland Hospital, which is a very sought after quad level trauma center. Like they have people from Harvard coming over to do rotations there. It's just really high end exposure. So they get a very excellent exposure, much better than I had. My rotations we could talk about. We did. I did do anesthesia, I remember, and they didn't have orthopedic residents that when I did 2-year program where we were. So we were the orthopedic residents. I think that was the plus of the program I was in. We had a month elective, which I did in plastics, which is another interesting, funny stories. But there's a so it's a little bit different. It's more structured now. When our residents getting to the second year, I know they feel like they haven't seen feet enough by then, but they get over it very quickly. So the concentration happens in foot and ankle surgery this second, third year primarily. We have a very close relationship with Kaiser San Francisco because our residents do a quarter with them in the third year. They take our residents to treat them like their residents. So we have a very close relationship with them, and they do a lot of trauma. So that's actually, good for us also, I think. And I think the biggest plus of our program in a way is that they rotate with so many different practitioners. And this is not always a rule with residency programs where you kind of stay in one place and you get, you drink the same Kool-Aid and it's everything the same thing over and over again. And our residents come, I didn't know you could do it that way. Or they get exposure because people learn things and then they decide on their own when they get out. I know residents when Al and I had at Lindell Hospital in St. Louis, we had residents. So we did a lot of flat foot surgery back then. We get out and they just didn't want to do it for whatever reason. I think it was a bad commentary on us for them choosing not to do it, but I thought we had pretty good results, but you choose what you want to do when you get out. You need to have a general exposure thing, I think, so and the interesting thing with the UCSF connection we got absorbed in, the residents are rotating with me through UCSF. I get them for a quarter in the second year. They were in the PGY2s and they're in all the surgery areas and clinic and stuff. And so they're stuck with me. And I like to give them the one-on-one because my thing with teaching, which is maybe a little different, Jeff, with Kern, they very emphasize the technical aspects, right? There was always you would do 800,000 arthroplasties until you go on the next level is different. And I think that's important. But I think one advantage of having multiple years also is that I try to make their brains work right. I really think that surgery is a brain thing. It's the technical stuff has to be there, but it requires a deeper thought. You can't just cut here. That's not learning things for me. I also realize I like imaging stuff. I spend a lot of time with the residents one-on-one, learning them how to read MRIs because I've had a very close relationship with the radiology departments in St. Louis. I published a bunch of articles with the radiologist at Stanford when I was there that are in radiology journals. And I always found that interesting because I think you have to become your own radiologist nowadays because the radiologists are too generalized. If you don't know how to read an MRI better than the standard, community doctor radiologist, you're going to probably be in trouble. So I am trying to emphasize that. So I think it's become a very good. I think the breadth of information is so much deeper now, right? Like when we started to do more reconstructive surgery and more ankle surgery, that got laden on top of all the other requirements of podiatry. I think that's what makes podiatry interesting. There's so much we have to know. I think it's really a challenging profession. You have to be a neurologist, a dermatologist, a surgeon. There's so many parts of being a podiatrist. And in fact, I like all, most of my practice is very surgery based, like where I'm at UCSF, I'm not allowed to do primary podiatry care anymore because they want me there for surgery and reconstructive and sports stuff. And they know I'm the only podiatrist in the orthopedic department. And they say, if you open up that door, you get flooded by the primary care doctors. There's a lot of them. They said, you're going to drown, They said, that's not why we have you here. We can talk about the building, the department, and add that on later on, but not now. It's okay. So it's good. We have a really good program. We love to have students with us. I think we got a bad reputation that we only took Samuel Merit students because they do their rotations a lot through Highland Hospital, which is manned by our people. That's really not the case. I was very happy to see this year that we had applications from all the colleges. And we want Arizona students. You guys are so close to us. We really should develop. We get, Western students too, because they're close. We should have that closeness should be an advantage to your students to be able to visit easily, and I'm happy to help with that in any way.
Yeah, we can definitely have a conversation offline
we can talk about that.
Those kinds of opportunities because that would be, I would love to explore that with you. I really appreciate some of what you're describing about watching how it's evolved over time and appreciating, we want to continue to advance the profession. We want to continue to hold high expectations and meet high standards. But there are some things that are very unique about podiatry that we want to keep as unique in podiatry. The blend of things like biomechanics and surgery, it's not one or the other. You don't pick, I do biomechanics or I do surgery. It is a combination. You need to understand all of those things all of the time. And I'm curious, in terms of some of the academics and things that you offer for your residents, what does that look like for them in terms of structured academics? How often do you guys do things like a journal club or?
Yeah. So we have weekly meetings. We used to get together in person. I think the pandemic kind of impacted that. So we do Zoom things now. I kind of missed the togetherness, but we always have everybody's able to attend our meetings now. When we had get-togethers in person, people the only negative to our thing is like you have Bay Area traffic, so like 5 miles could take forever. It's like so like we'd have people not making it in time. So this is good. So we kind of structured it like 1 week of the month will be journal club, and they'll be topic oriented. Like we've had neurological emphasis 1 month, and now we're talking about congenital deformities. So the articles will be tainted that direction, kind of turned in that direction. Okay, and then another week will be case presentations. That can be anything. So all the residents will bring a case from their rotation back to the table for a discussion. And sometimes the attendings that they work with in an outside institution will want to be there with that presentation. And that's nice when you get the author of the procedure selection there, which is not bad. And then we have the residents are required to give a presentation, and they usually will present a topic, and there'll be attending attached to that lecture too. At the end, they'll show some of their cases on what the resident talked about. So we have a pretty intensive program. And sometimes we'll have put that in charge of the chief resident, where they'll have the commercialization where some product might be presented. Of course, the residents get a free meal out of that, so they're very happy about it. But and we try to make sure those things that are selected do have some value added to their information, not just because it's out there. Okay. So we do that. We put on. I did something that I really like. We put on a Bay Area Residency Forum, which I started. I got buy-in from all the programs. This was something that wasn't my brainchild. It was something I experienced as a resident in the Philadelphia area, where the programs would all get together every now and then and present cases. So you got to see how other programs were doing that. So so I approached the two VA hospitals in the area, all the Kaisers in the area, Santa Clara, San Francisco, this and that. The other programs have asked to join us, but it becomes a little congested. So what we do a couple times, 2-3 times a year, we have a topic-oriented presentation. It might be complications, it might be rear foot, and we present cases, and the attendings like to come on, and we serve as a guide, trying to give them some attending feedback on a topic that's presented, and was the case appropriate or not based on their past experiences. Appropriate is probably not the right word, but there's and we have a lot of discussions. So that's the whole Saturday. Okay. The other thing we do is we put on an annual meeting. Also, I think this is something some programs I've got calls have started the same thing. We have a lot of resource we can give back, and we put on a seminar, which is interesting, and once a year, and we do it again. It used to be in person, but then it kind of became Zoom, and we're thinking about going back to hybrid thing, because we have great lecture halls at UCSF we can use now. But there's and I try to bring in. We've had invited speakers. We have some of our teaching staff do that. Two of the foot and ankle orthos I worked at PAMF, the Medical Foundation, they love to come to this. They really enjoy it. They're the people that the last one's out the door. I mean, they're so educationally oriented. Really, when we got together, they would still be seeing us like amazing. They just we all like to learn. If you're in that kind of environment, and so we put that on, and we've had some big name ortho, foot and ankle, Coughlin. We've had some really big name people come in as invited guests. We had Alan, come in one year and stuff, and so we try to get an outside lecturer as well, and we make it free to students and residents. We charge a very small amount of money so that we can go back into our research program, from attendings, but it's like a pittance type thing. We just want to have people there.
Yeah. Jeff, your thoughts. Otherwise, I'll jump back in and ask follow-ups on some of the things he was saying.
So, Larry, one of the things I was going to mention, and it highlights the nature of our wonderful profession, is you mentioned Dr. Tom Malillo. And when I became a dean initially, he was so gracious in helping me, understanding things like curriculum reviews and things like that. But his daughter, Jana Kraleski, is on faculty with Joe and I.
Are you kidding me? Oh, my God. Yeah. Did you tell her that her dad was my residency director?
Absolutely.
Wow,
so that's fabulous.
Yeah, wow.
So, Larry, I had a question regarding students. What does a month look like for next term? Let's say one of our students from Arizona comes in and spends a month.
The thing we have to evolve, I'm sensitive with the UCSF part right now because we're just in the door. I just don't want to flood the area yet, but I have lunch with them. Whoever's a visiting student, or you have them come down to UCSF, I have lunch with them so I can have some face-to-face time with them, and also to ask them any questions, get their feedback. So they rotate, so one of the rotations I have is a big conglomeration of foot care called Bay Area Foot Care. It's one of those mega practices. with investment banking money. We see that popping up all the time. But it didn't start like that. It is like that now, but it's right in the hospital. It's in the hospital, St. Mary's Stanton Hospital's medical building. Okay. So they do all the cases over at Stanton Hospital, and they just walk across the hall and go, do that. So they rotate through there. They rotate through Highland Hospital also. We have Dr. Miller, who's in North Bay, does very high surgical volume, likes to do a lot of TARs and stuff. And so the students will kind of make their rounds through those things. So they get a good smattering what the program's like, so they all come out pretty excited. They come out, at least they're, I don't know. They seem to be excited when I talk to them. They seem to, like it. And it seems like they're learning those things they haven't seen. We have, there's a lot of wound care that's involved in the Bay Area foot care rotation. They have quite a bit of that, so they're really getting a little bit of everything, I think. It's good.
That's great. And to your point earlier, I think many of our students always thought that it was a Samuel Merritt designated.
Yes. Yeah. I made a very concerted effort, not, to really try to, I do think it's valuable to have students from different backgrounds, different educations. I think they kind of feed into each other well, So, if we have two candidates that are equally competent, I shouldn't give away all the family jewels here, but we got to try to choose some from the other college, for that reason, so.
Totally fair. Wow, that's great. Joe, anything else regarding the residency?
Yeah. So, question I always get from students: can you talk a little bit about call structure? How does it kind of work for them? Do they take more in the early part? Do they take it more at the end of residency? Do they take it all the way across? No change? What's the call structure look like?
I think they're doing shared call for the most part. I think that like my resident doesn't take call, for example, who's rotating with me. It's kind of interesting. What's happened right now that'll probably change, the orthopedic department's taking my call right now. So in fact, I got a message from one of the PGY3s. Oh, I'll let you know, Dr. Olaf, I still want to talk to one of your patients, blah, blah, blah. Well, we can't probably do that forever to figure that out. But there's a, so what happens is my resident who has the fluffiest rotation with call will help serve some call on weekends for the Stanton Hospital residents that are very overloaded, So we try to give them a break. And everything else is pretty reasonable. At Kaiser, they're sharing the call and stuff like that too. So, so those rotations are fairly intense. The first year, not too much really. Like because of MedHub, I can see how much if someone, you use MedHub too, what that is? It's kind of like, it's where our evaluations come through. A lot of the university systems use it. And if someone it tracks their hours, okay? So when we were residents, we got, it was like the war stories. Oh, I was on call for, 40 hours. Well, that doesn't work that way anymore.
Yeah.
There have to be, there's a limit, it's structured. Our residents have one of the advantages they have becoming UCSF residents is their stipend, their salary has gone up astronomically, like it went 50% higher. So it's all like around $100,000 a year. It's amazing. I actually asked if I could be a resident again. That wasn't so bad. So for PGY3 is a little bit better than that, actually. It's amazing. They're all and they're all parts of unions now and stuff like that. It's interesting. It's different, So we have one of our resident services a union representative. It's like it's a much different world. So the call I don't think the call is like oppressive. And if we see someone's drowning, we're going to make an effort to remedy that.
And there's so much value in taking call. They're going to come out and take call when most of them will probably come out and take call. Not everyone. You do have opportunities to choose not to take call somewhere. But I think most practitioners out of residency, especially the ones that are kind of centered towards surgery, they want those opportunities to get cases and introduce themselves to hospitals. So they're going to be in those environments. So having someone there to bounce ideas off of, someone else as a sounding board, that's such a valuable experience.
Absolutely. And, it's one of the things we had to fix even recently is sometimes junior residents are not thrilled about asking for help. They think it's a sign of weakness or whatever. And we're saying, we're here, we're a family, we're here to support you. And that's what the third year residents are there for, to bounce things over, because that you're absolutely right. That is a learning experience, knowing what's serious, what's not, what can wait, what can't. You have to go through that. It's part of the learning experience. And when should you run in? When should you do a reduction? I mean, you need to be familiar with that stuff. And sometimes there are ER atmospheres where the ER docs know how to do that. Maybe not as well as we do, but they do know. And, and other times they don't, or they get nervous about things. You have to be exposed to all that stuff. I know, I'm sure it's like exhausting. I understand. We've all been through this. It's a little bit, it's not just a rite of passage. It's a passage of education, and you have to go through that.
We all know that early detection is the most important determination in improving patient outcomes. Bako Diagnostics remains committed to supporting you in your role as the first line of defense in diagnosing lower extremity pathologies. Bako Diagnostics, helping podiatric physicians keep America on its feet.
Yeah, and it's interesting as I talk with some of the students is they're thinking about, there are so many things that our students are juggling now. A lot of them actually have families. And so sometimes it can be framed as, oh, you don't want to take call as you get, this program is better because you only take call as a first year. And I think that that's really misaligned. I'm not saying that it's better or worse, but they are different. And I think it's important for students to have the opportunity to think to themselves, what do I want my future self to look like? What kind of practice do I envision I have? And then from there, we work backwards, right? So if I'm going to be taking trauma call at a level 1 hospital center, I don't want to have the last time I was taking call as a resident was a first year where I didn't really understand key important surgical principles, because now I'm going to be by myself with my license and my name on this patient's record. And I don't have the same kind of mentorship readily available. It doesn't mean you still can't ask for help. And if I could help advocate for anything, it's that we ask each other for help so much more frequently than we do. But I feel like our students are sometimes getting the wrong expectation of call. And I'm not saying that I think that it's great that you take call for 3 years straight, because certainly there's a fatigue that comes with that. But there is a trade-off that when you're a third year taking call and then you graduate and you take this great paying, wonderful benefits, high hospital-based career, you own it now. And you have to be ready for that. And to be eligible to kind of go down that track, in my mind, you want that confidence that leads itself to competence to take those kinds of cases on.
100% correct. Okay. And sometimes a lot of things just seem like war stories, but my worst call was my elective month was on plastics. It was an area, the call I wasn't familiar with, and this is going to be a R-rated conversation for a second. But I remember this guy did everything. I remember the second. I think I told the story last time. The radical neck. Did I tell that story to you guys? No, so like the first story went in, he was doing a breast reduction, and I'm thinking, why am I here? But I was suturing. Okay. The second case was a radical neck with just him and me. I never saw blood vessels that big, and we don't see blood vessels like that in our world. And he's had me tie off these blood vessels. Okay. So one of my sutures came off, and there was quite a bit of blood, and I remember he didn't get angry with me. He leaned over and whispered, "Tie it tighter next time, please."
Right.
And with my shaky hands, I, okay, doctor, this, and there was and I remember, but this call, this is the R-rated part. I mean, there was just stuff I was unfamiliar with. He did everything. So I remember he did a penile implant on someone. And I had guys calling up late at night. And you can imagine what questions he was asking. I didn't know how to answer that. I had no idea what was allowable, what wasn't allowable. I said, "You're going to have to put that off to tomorrow until the doctor's back in the office. I can't answer you for that." So I used to get a lot of that, a lot of flap stuff. It's because I felt a little intimidated, but it was, all that stuff was good. It's like I look back in retrospect, it was good, Yeah. And so I think I agree with you 100%. I think that's part of your education. I just, it may seem like a burden, but when you get out, you realize, I'm glad I learned that. I'm glad I was there for that.
Yeah. And like, if we can reframe some of these stressful, challenging situations that really do help us grow and be better if we take the opportunity to learn from it. If we can take that and look at it as, this is my experience, like that ownership, my experience to learn, that changes that perspective of, that program I have to take call for 3 years straight. Like that just sounds exhausting. It is exhausting. But to your point, there are a lot more protections in place. It's not like we're going to ask them to do something that's unsafe for themselves or their patients that they're taking care of. But when we've changed some of the work hour restrictions, the flip side or the trade-off is, because I remember this started coming kind of downstream. I was a second-year resident when we weren't part of it yet, but we were having to log and like keep track. And I remember being so upset with Dr. Ford because I had been on ortho call all night. And I was quote unquote, I was fine. I was ready to go. We had cases. And he's like, you have to go home. And I said, I'm not going home. I'm here. I'm ready to go. I studied these cases. I'm ready. And he's like, I understand, but I'm not allowed to let you stay because of these work hour things. And I was just so upset because that was a whole day of learning that I now had to go home and miss out on. And it was, so again, it's an important trade-off to remember. You get 3 years to be excellent.
Yes. And then it's, you know what? You're the smartest then, and it's down after that. You know that? So, okay, one more story. So one time I was on orthopedics and someone got hit by, a pedestrian got hit by a car, fractured his femur, which can cause, you get a lot of bleeding from that. And I remember it was Christmas time and I was an orthopedic call, unfortunately. So I called in. I know the orthopedist was at a Christmas party. I know he's annoyed. He says, you sure I have to come in? I said, yes, I am 100% sure you have to come in. He was a little annoyed. Back in those days, he brought his friend down, at the party. They came in tuxedos. It was like showing being a little flamboyant. You couldn't get away with this nowadays. And he goes in, and the guy had to have a femoral rod put in, okay? And there was a blood shortage in the Philadelphia area at the time. And he chose, because of being so flamboyant, he chose the wrong size rod. It was too big. And these things, you have to hammer them out, if they're in the wrong way, right? So like a tibial rod. And there's this thing in there, and they're like, it's exhausting. We couldn't even move our arms after a while. He finally found an 8-foot-tall medical student to come knock it out. I remember, and thank God. But I remember the anesthesia, I was getting nervous. Doctors, his blood pressure is starting to drop. And I said, I sent for blood because there's a blood shortage. I called the police department, fire department to get blood. And there's also a snow forecast. This is going to shorter in a second, like 3 inches. To make a long story short, there was 4 feet of snow, 3 to 4 feet of snow. And because I'm into the ICU because his vitals were kind of thready and not good. The doctor said, I want you to stay with him tonight. I go, okay, I understand. Maybe it's quite a job. Okay. So, but we got stuck. There's one doctor and I got stuck in a 200-bed hospital for over a day and a half. Okay. We were the only staff that made it. You can imagine what the call was like. It was exhausting. Right? So the reason I'm getting to the end part of this, by the time next day before people came in, one doctor came in to do his surgery who was a proctologist, okay, to do hemorrhoids, the next morning because he lived across the street from the hospital. So the other intern and I, we're exhausted. We can't even stand up. And they called upstairs and they said they need one of us to come up to assist. I lost a coin toss. So I'm in there and there's nothing like an 80-year-old proctologist talking in a monotone voice when you're really sleepy, describing internal, external, anal anatomy to make you go to sleep. Okay. And I remember I was like this, I'm retracting and I started to fall forward. I almost fell into the guy's rear end. And the nurse behind me grabbed me, pulled me back. Doctor, you can sleep later.
Oh, no.
That was the worst part of that call.
Yep.
Horrible. But listen, I have a story to tell out of
it. and there are things that you learn from that. And
yes.
And sorry, Jeff, I know there's other things that we still also wanted to get to. But this brings me to another point that I've actually been thinking a lot about after a discussion with a student. And I'm curious what your thoughts are, Larry, because again, you have lived the life, you have done the work, as people love to say, of working alongside all types of physicians in a hospital. And we have this interesting kind of shift in terms of ownership of patients.
Yes.
What are your thoughts about, we shift to some of these, and again, appropriate for safety, and there's good and there's a flip. There are two sides of the same coin with the idea of shift work. but we're losing a little bit of the ownership of the care. As you just pointed out, you had a patient who was kind of on the fence in terms of their overall well-being. They go to the ICU, and your attending specifically said, I want you to stay with this person because you were in the surgery, you were in the ER with them, you know this continuity of care. Yeah. I'm curious what your thoughts are in terms of how do we bridge this gap between maintaining appropriate safety boundaries, but also keeping that ownership and not just being like somebody else's problem now. What are your thoughts on that?
That's a really good question. Some of this goes back to the training aspect. And Joe, you reminded me of something in our training. One of the other pluses, I think, is the ability to see patients afterwards, okay? Yeah. Because it's not about just doing the surgery. It's how to manage the patient, the dressings you put on, the little things that contribute to the success of the operation. You have to have that part. And sometimes what happens is we don't have, even our training programs don't have ownership of the patient. You don't see they don't follow them through, right? It's a problem.
Yeah.
So I think that's such a critical part of that, and that's when you learn it. And sometimes it's hard in group practice, especially when you have physician extenders. I have a nurse practitioner with me and stuff. I'm a neurotic doctor. I would really freely admit to that I want to see the patient, how they're doing. The little things I know make things work better, okay? But then you have to let them go because you're too congested, and some of these cases have to fall on someone else's plate. And it's really, this is a difficult problem. You're handing these over, so I did a very complex ankle fracture last week. It was really complicated. And so I just come back for his first post-op check next week. I called the nurse practitioner. I want you to watch for these are things I'm nervous about. I just want to plant some seeds, because I'm not seeing them.
Right.
The issue with that, send me a picture if you're not sure or whatever. So you have to be able to even touch these patients, I think. You can't just, you have to have ownership of them in some way.
And I like what you just said there, because what you also just did is to the next touch point, you left continuity. Hey, this is my concerns. Please reach out to me. Because sometimes where the disconnect also falls is not the handing off to someone. It's the handing off and washing your hands of it.
Yes.
But when if I was that nurse practitioner and I knew, all right, I see this patient and I don't know, I'm kind of on the fence. I don't know, do I take the stitches out? Do I leave it? Right. I know that you're not going to yell at me if I reach out to you and say, hey, what do you think I should do? Because you left that door open.
Yes. Yeah.
And I like that.
I think it's funny. And the other part was like the extension of that thought. One of the residents said to me, wow, you must feel good. You were able to put that back together. This was, it was incredible. And and they said, no, I won't feel good until a year afterwards when I know the patient's okay.
Yeah. All the sleep that's lost.
Yeah, right. So that's different. It's back to your idea. The job is not done just because you put it back together.
Yeah. Sorry, Jeff, I totally hogged this one.
Oh, that's all right. Larry, you had touched on something I think is really important for all of us that are training students. It's a two-way street because I was a clerkship director for 10 years. To your point, the students kept me on my toes and residents.
Good, right?
And there was no downside to it. It was just wonderful. And so I think some of the unsung heroes in our profession indeed are the residency directors and the doctors that bring their patients to help train the next generation of podiatrists.
Yes. There's been some recent items that pop up in some of our things about, how our residency directors, they're selfish to present progress, changing. I won't get into too much details about it. We can talk more about it. That is so unfair. If I was going to live on my stipend that I got for being a director, forget it. My wife was always going, when are you going to give this up? This is not worth your time. No, it is worth my time. It fulfills me. It's not the money thing. The money's obviously not worth it. It wouldn't make sense. Make much more money in private practice, without question.
Yeah. Well, it's to the point that it's a calling more than a job. Remember, speaking of current, I remember Dr. Kennett said, never say you're applying for a job. You're applying for a position that will take you to the next level in your career. things like that are just interesting.
Yeah. So Mark Carno was my first choice. And you know how they would always take like two students. They go through one interview and then with another interview, and they pick two students to the top of the class, whatever. So you had to be in top of your class, Jeff. I can tell by that. Otherwise, you're
they made an exception for me, Larry. I don't know what to say.
So I remember it was down this other guy and we got down to the final interview. So I'm sitting there and I'm sailing through the interview. And the other guy said, "You're number 1 or 2 in the class. You're going to get it. I'm not going to get it." And he was like number 3 or 4 or something. I said, "Well, who knows?" So there's so he goes, so you go in there. Earl Kaplan's in the room. Okay, one of the fathers of foot surgery, right? And I thought he was sleeping actually. Through my interview, his eyes were closed. I remember. And then we get down to the last question of the interview, and the question was, "What don't you like about yourself?" Did you ever get that one? I don't know.
I did not get that one.
I didn't, I didn't know what to say to that. Like I said, I'm a little obsessive compulsive about things. And I saw Earl Kaplan's eyes open up and his raspy voice. "What do you mean by that exactly?" Now I know I'm in trouble. I dug a hole, right? So I said, well, if I pick up a good book, it's hard for me to put it down. So I'm like backpedaling things. I created a hole I couldn't get out. And the other guy got the program.
Oh, no. I didn't have an opportunity to work with Earl. I did meet Earl, but he had retired, but I worked with Gary and Dale and Randy and all the whole gang. Dr. Cannett was my residency director one year.
Dr. Cannett was my wife's surrogate uncle, actually. My wife, I married now in the 3,000 years, 45 years, was the daughter of Werner Strupp, who was the APMA counsel.
Oh my goodness!
And that's how we have very podiatry history here. And Arthur Helfand was very close to her father. And when I was a student, I moved to Washington D.C. for the VA job. They lived in the Washington D.C. area. They gave me a note before I left. "You should call the APMA attorney. She's very nice. It's a really nice family." So the typical guy thing, I stuck in my wallet. I wasn't a blind date type person. And I'm cleaning my wallet like several months out, and I find a note. I said, I just had broken up with somebody. What the heck, And look what trouble I got in 45 years later. He referred to his wonderful man, Uncle Irv.
Yeah. I always, Joe, you've heard this story before, but Irv was wonderful. It was very simple at Kern. We came in the first day and we met in the boardroom and he said, "I'm going to know what you're doing every day and every hour for the next 2 years. You get 3 square meals a day, you get scrubs." And it was very simple. You showed up at 6 a.m. and you went home when the work and lectures were done. Very, very straightforward. He was awesome. It was best years ever. I was one of the best things that ever happened.
Great program. Everybody came out there. It was wonderful. This actually really good.
Really enjoyed it. So, Larry, I had planned to do kind of a Dr. Olaf unplugged segment. Okay. And there's some things I want to talk about, right? I mean, there's some hot topic items in our profession right now. Yes, the Accreditation Council for Graduate Medical Education. I mean, you hear ACGME going on all over the place. You hear about plenary licenses. You hear lots of issues online. I'm going to go out on a limb here and ask you if you'd be willing to come back for a 3rd episode.
Oh, yeah. Okay. I'll do that for an unplugged thing. I'll probably get myself in trouble with things I'll say, but yeah, I would love to talk about that. I think some of these issues keep coming up. Some of them are not new issues. They're old. The plenary license thing is around since I was a student,
Right.
And all the insecurity related to that was why I applied to medical school. I remember, and I said, well, maybe I should change, but maybe I'm going the wrong direction, and I got in, but I changed my mind last second. Great choice, and there was a, I love to talk about it. It seems to resurface all the time, but I understand it because I shared those sentiments. I don't share those sentiments anymore, and I'd be happy to talk about that. Absolutely. Yeah.
Okay. Well, we will get that on another episode coming up. I think we could do the Dr. Oloff series. It just could be one after another. love reminiscing.
Yeah, there's some fun opportunities here.
Everybody a headache.
No way. It's awesome. Larry, thank you for joining us again so much. Oh my gosh, we could talk forever.
It's so much fun. I feel like we're out having a beer, all talking together about the profession.
Right?
Doesn't it feel like that?
Well,
Yes.
I love to talk about this stuff. I think that, like I'm in the tail end of my career, and I just, and I think they're good things to talk about that would help other people, and that's why I like what you guys do so much. I just think I think it's wonderful, and I think some of the unplugged thing we talk about maybe could serve as a platform for that from people from different sides, even.
Yeah.
There's all this chattering and it's, the information that goes out. It's very confusing. I just, it does need some clarification. And I'm not saying that anything has to be decided about this. I'm not saying that, and it's a changing landscape. I do think that that changed my perspective on things is much different than it was 30 years ago. I have a totally different perspective now about that, so, and going through the environments I've been in, which have been really more medical than podiatry environments. Where's Waldo? I'm something else. I'm on some medical weird thing, and what that's like, and what perspective that's given me, and why that's kind of structured my opinion on things. Might prove helpful to some people.
Well, we're going to tap into your knowledge and experience and wisdom on Dr. Oloff Unplugged. We'll schedule it. Joe, any last comments?
No, thank you so much for sharing your time with us, Larry. As always, it's just so fun to chat about all these different things. And then you'll say something I'm like, oh, I really want to pick your brain about that. So I just appreciate your time and your willingness to come and share your experiences with us and the audience.
Well,
so thank you.
It's just fun being with you guys. I can do this. This is not an issue at all. I mean, it's fun. I enjoy it. You took me away from Monday is my paperwork day where I'm catching up the charts that are a month old and all this stuff that I can screamage about, and got a bunch of research projects going on, gives me a chance to move forward on them. So you gave me a break from that. So it's good.
There you go.
And also it gives me a chance to talk to my old dean. I love it. All right, everyone. To all of our listeners out there, if you're listening on Apple or Spotify, yes.
I got the cup. Thank you. I just got out of the box, but I didn't put coffee in it yet.
That's great. Please become please give us a 5-star rating, and of course, leave a comment or two. And if you're watching on YouTube, we'd love for you to become a subscriber. Dr. Olaf got his Dean's Chat cup. I'm psyched about that. And we look forward to our next episode with you, Larry. Thanks again.
Perfect. Thank you, guys. Thank you. Perfect.
Okay, bye-bye now.
See you soon. Take care.
Cheers.